Thank you. Board Member Doyle speaking. It's 1:06 p.m. Friday, June 14th. We're returning from lunch break and resuming open session at the Board of Pharmacy meeting for June 2024. Couple of housekeeping announcements, so to speak. Number one, you had all been presented earlier at your tabletop the Robert's Rules of Order book. Now that that has been approved as the methodology for running meetings, that copy is yours. Please take them home with you, not including Board Member DeBarmore or myself, of course, but take them home and have them available at your beck and call for reference as necessary. The other announcement has to do with iPads. I'm informed by that member Melvin that at the end of the day, she will need to pick up each and everyone's iPad for some reprogramming purposes. And she'll make an announcement later this afternoon. But I know that sometimes we start to lose attention span at the end of the day, and we don't want you to walk off without getting the iPad to her first. Any more on that right now, staff member? We left off discussion with mailing G1, mailing G, the Lincoln County Public Health and Human Services SBAR. We have a hanging chad on that one, so to speak, with regard to a second bullet point that we are going to address at the end of reviewing these first three SBARs, G, G1, and G2. Now I turn it back over to Staff Member Davis to walk us through SBAR Monroe Health Center CHC mailing G1.
All right, Staff Member Davis. So similar and yet different to the waiver request that we just looked at. Monroe Health Center is a rural school-based health center located in Monroe, Oregon, and they're seeking a review and approval of a waiver to their community health center rules. It's the same rule that we discussed earlier. However, they are different. The center is obligated to provide family planning services as mandated by school-based health center requirements. They have a PA who serves as the primary provider at this specific location and is qualified to offer these services. Our current regulations do not permit a physician assistant. They will shortly be called physician associates. There was a bill in the last legislature to change their name. From accessing the drug cabinet and room, and thus dispensing family planning products, which is hindering the center's ability to deliver these essential services. So the assessment restricting access to only a physician or someone else that would have that authority, but a PA traditionally has been working under a physician. They have a newer, kind of more independent authority now under the state regulations. It's the name change, and a lot of the rules of laws are changing around them. It's creating a little bit of a bottleneck for them in service delivery, and then granting access to the PA would improve efficiency and ensure continued service. They did provide us with their security and storage information. So all drugs in this Monroe Health Center are kept in a locked drug cabinet or designated storage area that is sufficiently secure to deny access to unauthorized persons. The cabinet or drug storage area is locked and secured when not used. The key to the locked cabinet is placed in a lockbox, and the code is only given to providers who are authorized to access those medicines. In terms of training, then they go over this during new staff orientation. They review the medication dispensing protocol. They review the policies of the community health centers in that area, and information on drug storage procedures and information on counseling. They also do a competency assessment related to dispensing, but we're not talking about dispensing here. We're just talking about access, and they document the training that's placed in the staff's personnel file. The medical director or their designated representative must conduct and document an annual review of the pharmacy portion of the outlet of the drugs. Their completed form is filed at the clinic and available to the Board of Pharmacy for inspection for 3 years. So for board discussion, would approval of the waiver for OAR 855-043-0720 to allow a PA to access the medicine room, further public health or safety or the health and safety of a patient, and if approved, we would like to get a time frame for approval for this waiver. Back to you, Board President Doyle.
President Doyle, thank you. We begin answering that question with Board Member Joyce.
Board Member Joyce, definitely a PA approval for 3 or 5 years.
Member Patel.
Member Patel, yes, PA, their provider, so definitely they can have access. 3 years, fine, 5 years, fine.
Member Hemmings.
Board Member Hemmings agree with access for years.
Member DeBarmore.
Board Member DeBarmore, yes, 5 years.
Member Hall.
Member Hall, yes, 5 years.
Member Beeman.
Member Beeman, yes, 5 years.
Member Doyle, yes, 3 years. Board Member Chin.
Member Chin, yes, 5 years.
Is there a motion to approve the request for Monroe Health Center as presented for a period of 5 years?
Move Board Member Beeman.
Second, Board Member Chin.
Motion has been made and seconded to approve the request for Monroe Health Center as presented for a period of 5 years. Now call roll. Board President Doyle, yes. Board Vice President Chin.
Yes.
Member Beeman.
Yes.
Board Member DeBarmore.
Yes.
Board Member Hall.
Yes.
Board Member Hemmings.
Member Hemmings, why we are approving for 5 for this one, 3 for the previous. This is Board Member Chin. I'd be happy to.
Board Member Doyle, we already have a motion on the floor, and so we'll need to continue that. Discussion had been closed.
Board Member Hemmings, you closed it without asking if there were any additional concerns.
My interpretation, because we went through, everybody had a chance to speak. Council Bertoni, can a motion at this time to be withdrawn? We need to continue through.
AAG Bertoni, the Robert's Rules of Order is only used to the extent that the board chooses to use it. So if the board wishes to be more informal and withdraw the motion, allow the discussion, that would be fine as well. The thing that matters the most is that when the motion is voted on, it's clear what the motion is, that it's seconded. Draw the motion, have discussion.
A motion to withdraw the discussion.
Board Member Beeman motion to withdraw the motion.
Second.
Motion has been made to withdraw the discussion. Board President Doyle. Yes. Board Vice President Chin.
Yes.
Board Member Beeman.
Yes.
Board Member DeBarmore.
Yes.
Board Member Hall.
Yes.
Board Member Hemmings.
What are we voting? To withdraw the motion. Member Hemmings, yes.
Board Member Joyce.
Member Joyce, yes.
Board Member Patel.
Yes.
Board Member Hemmings, can you please repeat your question? Discussion.
Board Member Hemmings, my question is why we seem to be agreeing on 5 years. This, but gave 3 for the other one.
Member Chin.
Member Chin, be happy to address that. An LPN traditionally does not have the authority to do this, and so a shorter leash on how they work this SFAR and checking in again with them in 3 years is important. Where a PA has been a licensed provider for years, there is no question about their safety and ability to have access to a drug cabinet. And having them come back in 3 years, if rules don't change, doesn't make sense.
Member Hemmings, so you're giving more weight to a PA's license versus an LPN license.
In terms of patient safety, absolutely. It was because PAs weren't included in rules because traditionally in the past, PAs worked under, they've never been in my lifetime direct supervision, but they had a supervising position. And that has changed over the years. And so they're recognized as independent providers and just like a nurse practitioner is. And so there is no reason to not allow this licensee as an independent, an LIP, like everybody, like all of the rest of them, except for the RN, are in our rule to have access for 5 years. It's just because things have changed for that level of LIP, but they are independent from them.
Board Member Hemmons, I thought that PAs worked under an MD.
They do not necessarily work under an ND anymore. So there has been a national movement, but also legislation in Oregon to not only change from a physician assistant to physician associate and not have to have a overseeing physician.
Member Hemmons, thank you for that. I'm just trying to assess for inequities in terms of our decision making on the board, which is why I'm asking about why 3 versus 5. Thank you.
Does that answer the question? Okay.
Answers my question, doesn't change my opinion, but yes, answers my question.
Okay, so okay.
Any more discussion? Is open for someone to make a motion.
This board member Chin, I make a motion that we accept the Prairie City School-Based Community Clinic proposal for an exempt.
Michael.
What's up?
Michael.
It's Monroe.
Monroe.
Monroe
This-
Health Center.
There you go. Oh, I'm done with that one.
I'm on to the next one.
I'm sorry. Board member Chin, motions to accept the Monroe Health Center exemption request for 5 years. Board member Beeman, seconds.
Motion and seconded. Now call roll. Board President Doyle, yes. Vice President Chin,
Yes.
Member Beeman,
Yes.
for the bar.
Yes.
Board Member Hall,
Yes.
Member Hemmons,
No,
Member Joyce. Yes. Member Patel.
Member Patel, yes.
Motion passes. Board Member Hemmons opposed. We now move on with Staff Member Davis to Miami G2, that's Golf 2, Prairie City School-Based Community Clinic CHC.
All right, so Prairie City School-Based Community Clinic is a rural school-based health center in Prairie City, Oregon, and seeking review and approval of a waiver request to the Community Health Center security rules, same rule that we've been discussing for the last 2 waivers. They have a single nurse practitioner with access to the medication room who's responsible for dispensing medications. To ensure adequate staffing and patient care, they are asking for an additional medical assistant to have access to the medication room. In the clinic, the MA has access to a storage room that has supplies, swabs, bandages, etc., which is also the same room that medications are stored in. MAs are not licensed in Oregon. However, the Oregon Medical Board only provides guidance to licensees when utilizing medical assistance. I also had checked with the nursing board about them utilizing MAs, and it was a similar philosophy. So the assessment was restricting access to only the nurse practitioners, creating a potential bottleneck in service delivery. Granting access to the MA would improve efficiency and ensure continued service. And they do have an existing waiver approved for the clinic's affiliated site, which is Grant County Health Department, which also permits MAs to access their medical room. Our understanding is the 2 sites are set up pretty similarly. And so we did go out to them and ask for additional information on their security and safety. The clinic does not store any controlled substances on site. They store emergency medications such as EpiPens, naloxone, birth control, nebulized medications, albuterol, antibiotics, antibiotic injections, allergy shots, and patient-supplied medications such as behavioral health medications or hormones, vaccines, OTC medications. The CMA would have access to all the medications, but would not be obtaining, using, or administering many of the medications. The CMA is also a backup vaccine coordinator and needs to be able to access the vaccine fridge and freezer in case of emergency when vaccines are received, and to access needles or syringes in order to administer the vaccines per OHA's orders. The CMA may also need to access the room where the medications are stored at times when the NP needs help with a procedure or to obtain additional supplies needed during care. There are only 3 staff members in the clinic, so this would be beneficial to their services and care. For training, the CMA has reviewed the pharmacy policies and procedures, vaccine ordering rule modules that they have, and does have the NP double check any vaccine has been drawn up or medications such as depot shots. They're going to complete their annual training modules as required by OHA for vaccines. And the NP has observed the CMA doing tasks such as administering vaccines, setting up and starting nebulizers, placing oxygen, and drawing up and administering injections. In terms of drug safety oversight, it's completed by the clinic and the school-based health center coordinator and the NP. They just started storing medications. They're a relatively new office. So they only have 1 month worth of monthly medication logs and counts currently, but they will continue doing monthly inventory counts with both the CMA and the NP. When inventory is received, 2 people assure that the packing slips and supplies are received or correct, and any missing items, they contact the supplier. They'll be documenting on the self-inspection form this month and then yearly. And then they annually have the Grant County Health Department, which is their umbrella organization, have local pharmacists that do an annual in-service on staff about access to the medications, reviewing the self-inspection form, along with education on medications that are relevant to their practice. And they review storage policies that pertain to medication. That's about it. So if granted, they'll update the policy to permit the MA to be able to access the medication area. Back to you, Board President Doyle, for discussion.
Been discussion with Board Member Patel.
Board Member Patel, in my right consciousness, I cannot allow that. It's MA, they're not licensed. And correct me if I'm wrong, you said like they also store the patient medication on the same medication?
It was included in her that they have supplied medications such as behavioral health medications or hormones that are patient supplied.
Yeah, that's the patient supplied, so. I mean, MA, they're not licensee. I don't feel comfortable to give access. It's like a technician, even though they are licensee, they cannot enter into the pharmacy without pharmacist. We are going to allow MA into medication room where they're also storing patient supplied medication. That's something for me, it's a hard no, unless someone convinces me. Thank you.
Member Hemmons.
Member Hammond, so I have the same question that I had for the first one. Why does the MA need access and what are they gonna do with that access?
So my understanding from this one gave me a little bit more information, was just that it's one room that has everything in it. So it's got the bandages, supplies, swabs, vaccines, everything. And so if they're assisting in a procedure and they need to go grab some more bandages, they have to have access to the room. It doesn't appear that they have a separate locked safe where the medications are kept from the information that we've been given. It just appears that everything is all in one room that is locked, but that's creating problems.
Say it again. Oh, yeah, sorry.
Board Member Hemmons, so room that the medications are in also includes things such as supplies, medical supplies that the MA needs access to. But as far as we are aware of, the medication is not locked in that room, like in a separate
That is our
bed or
understanding.
anything like that. Okay,
That's our understanding. She,
you go up, move on, and come back to me.
and the community health clinic representative is on the phone, and we can unmute so you can ask questions if you would like to direct a question to her. No. Okay. All of this time.
Member DeBarmore?
Board member to Barmore. I can appreciate the challenging situation in a small community and probably a small thing or area, so making most of the space. I have similar concern with an unlicensed person. So I'm on the same page. It would be my recommendation to separate it within the room and lock up the drugs if there's a need for this, but I understand they're seeking access for the drugs too. That's what I heard in your presentation. Drugs and vaccine. I struggle with that. I don't know that I can agree to that. I do appreciate their circumstance.
Member Hall?
Member Hall, yeah, I wasn't really sure about this one. Be nice if maybe we could try to, just get the medications locked up, but it sounds like they want access to that as well. So, do understand this is all area, I'm assuming, so, right now, I don't know.
Beeman?
Member Beeman, ask how long their existing waiver for the affiliated site is.
I would put that to staff member Efferbaugh.
I have the same question. In looking it up, it looks like it's back from 2010 and there is no time limitation from it. But perhaps for the board's consideration too, because I remembered some more recent ones. So as of October 22, there was a CHC request from a location in Bend for an MA to access that the board did approve. And that was a re-up on that one too. So there was an individual that got 3 or 5 years and then was reviewed by the board in October 22 for an MA to access a drug room, and the board did approve it for a re-up at that time. This is different board members. The board can do as you see fit.
I agree with previous board members' comments about having unlicensed personnel with access. I was inclined to say no to this one, because of the lack of licensure and how that, how any issues or cases may proceed from there in terms of accountability. And I understand, and then the statement of philosophy pertaining to MAs. But I still am not in favor of allowing a non-licensed person access.
Board Member Doyle, no additional points or questions. Chin?
Member Chen. It's an absolutely opposite approach to MAs. MAs and even lesser trained UIPs, unlicensed individual persons have access and give meds all day, every day, under the direction of an RN in all of our facilities. These are not people who have had any formal training like MAs have had. RMA in all clinics, and we don't have LPNs and RNs doing patient care. They're all MAs. They all give meds. They all give vaccines. They all follow the protocols for what they are allowed to do. This MA is doing vaccines under OHA's authority. They need to have access to the vaccines. Whether or not they need that, they're not accessing the medications, they're accessing the room. Yes, would it be optimal to have a locked space that just has the medications that the NP needs optimally? Yes. But do I see any danger to the health and welfare of the Oregonians to have this MA who is under the supervision of a nurse practitioner who would be responsible for any patient errors, just for, oh, by the way, to have access? It doesn't make sense in terms of what we're trying to do for population health, not to allow somebody who is being managed and who is safe in all kind of environments in our state.
Board Member Joyce?
Board Member Joyce, so this is a rural, underserved area where healthcare providers are sparse. And I don't have a problem with MA accessing these drugs that staff member Davis listed out. Specifically, so I support this waiver for 3 years because to be consistent with similar requests for MAs to have access. I do strongly recommend that this facility lock up the medications. However, for this ask, I would approve this waiver for 3 years.
Member Evans, you have to come back to it.
Board Member Hemmings, I would agree with Board Member Joyce, in terms of the recommendation that the clinic figures out how to secure the medication, but I would agree to grant the waiver because there's precedence for it, for 3 years.
Staff Member Davis?
Staff Member Davis, like I said, the representative is listening to the conversation. I received an email saying that we can't lock the bed cabinets if needed. So you might want to put that in your motion as part of your reasoning that you're granting the waiver as long as the cabinets are locked. Something like that.
This is Board Member Chin. If the cabinets are locked, then there's not, that way they don't need an S-bar. I mean, that's my understanding. If the MA doesn't have access to the meds and they don't have to have the vaccines on because they do have rights and OHA rules for being able to access the vaccine, then they don't need an S-bar.
Would it be okay if I take her off mute so she can respond?
Yes, please. I was going to suggest that.
Jessica, can you unmute yourself so we can hear you?
Yeah, thank you all. So we are very, very new and still in the process of some renovation. So what I meant is we can add locks to the cabinets that have the medication in it, if that would help be able to have a waiver.
This is Board Member Chin. My understanding, and please correct me for staff or licensees, if the cabinet is locked and the room is locked just because of all the supplies, the MA is allowed to access the room, just not allowed to access the locked medication cabinet. And therefore you wouldn't need a waiver.
Well, so we just had our certification visit for our school-based health center, and they told us we needed to apply for one.
This is Board Member Chin. Who's the they?
Karen Vian from the Oregon School-Based Health Centers, I think is what it is. She's one of the nurses there that does the site visits.
Staff Member Davis, if, I think that would be correct in the situation you were in when you were being inspected, is that the drugs are not currently locked up and therefore you would need to get a waiver. But if you lock the drugs, the waiver is no longer needed. As long as the MA isn't accessing the locked cabinet. Now, if you're wanting the MA to access the locked cabinet with the drugs, then we still need the waiver.
There could be times that I would need them to.
Okay.
And I do know that we store like our bicillin in our vaccine fridge.
Okay. But what, just out of, this is Board Member Chin, out of curiosity, why wouldn't the MA, and I personally don't see a problem with it, but what would the MA be accessing anything besides what's in the vaccine fridge for?
Like say if they needed to get Tylenol for me to give somebody, if I was in with someone, or I'm trying to think what we have. We've got birth control in there. So depot shots.
So they are, so I'm sorry, I didn't understand who was on the phone. Are you the provider at this?
Yes. Mhm.
But you would be asking your MA then to get things out of the medication box for you to use.
Yes.
Rather than, and that would provide you with more free time
Yes.
with your,
Yep. And we have our locked emergency kit in there, which has like our epi and our naloxone. Those are in that same supply room.
and I think board staff, agency staff, Davis had gone over all the training that you've already done with.
Yes. And this MA has been an MA and a emergency EMT for almost 30 years.
I have no further questions and I'm still in support of your request, but it's, we have a whole bunch of people who need to make their decisions.
Mhm.
Thank you.
Thank you.
The floor is open for further discussion.
Well, this is Board Member Hemmons. Just to clarify, what specifically does the MA need to have access to that room for?
So that room has all of like our needles, our alcohol swabs, our Band-Aids. We're really small, so there's not a lot of storage space, but I mean, ACE wraps are in this room. Pretty much everything that you can store medical wise is in this room.
This is Board Member Hemmons again. Thanks for that. And the medication is in that room, but it's
Yep.
not in a separate cabinet that is locked.
No, it is in separate cabinets, but there are no locks on them at the moment. But if that's something we have to do, we can do it. But I would like her to be able to at least have access to like depot shots.
This is Board Member Hemmons again. What impact would it have if you were to put locks on those cabinets?
And we didn't have a waiver.
Correct.
Well, then I have to go into that room and get everything. So it take more time to see, like if she's just doing a depot shot when I'm seeing a patient, that patient would end up having to wait.
Thank you, Board Member Hemmons. Thanks.
Questions from the board for our guests or staff? Going to ask if there is a motion. My proposed motion for somebody to confirm will be, you will, the most unrestricted. And if that motion fails, then we'll perhaps add restrictions on it to the point where maybe a waiver passes. Is there a motion to approve, excuse me, is there a motion to move to approve the request for Prairie City School-Based Community Clinic as presented for 5 years?
So, Member Chin Summers.
Seconded, board member Joyce.
Motion has been made to approve the request for Prairie City School-Based Community Clinic as presented for 5 years. I'll now call roll vote. Board President Doyle, yes. Board Vice President Chin,
Yes.
Board Member Beeman. Oh. Member DeBarmore. Member Hall,
Yes.
Member Hemmons,
No.
Member Joyce.
Yes.
Member Patel.
No.
Motion passes with Board Member Hemmons and Patel in opposition. Thank you very much to our guest on the phone. We now have 1:42 PM. Staff Member Davis.
We're going to discuss the second recommendation for board discussion that we had listed on all 3 of the SBARs is, would the board like agency staff to begin drafting a rule amendment to modify the existing rule to permit a PA access, an LPN access, and or an MA access? That way we wouldn't be bringing waivers to you. It would just be in rule and it would be okay. So if you want to do that, discuss the amendment should modify the language to be similar. Rachel, if you can pull up the one of the SBARs, any one of them, so that you can see the language. So if what we're wondering is, should the amendment modify the language in the rule that's getting all the waivers to be similar to the rule that we have for dispensing practitioner drug outlets related to security? So as history, the CHC rules were written a long time ago. They haven't been touched. The DIPTO rules have been touched a little bit more recently. And so their language is different than what you see in the CHC rules. So it says all drugs must be kept in a locked drug cabinet or designated drug storage area that is sufficiently secure to deny access to unauthorized persons. The drug cabinet or designated drug storage area must remain locked and secured when not in use. So it's not specific to what types of providers. It's a more broad rule that puts it on the person that can or can't have access. And then obviously the next question would be, if you do want to see an amendment to this, then we'll need to talk about priorities next. But first, we wanted to get a feel for if the board would like to stop seeing waivers for some of these things and modify the rule. Back to you, Board President Doyle.
Member Doyle, the question posed to us is whether we want to continue to see waivers or if we want to see rule changes. Board Member Hemmons.
Board Member Hemmons, continue to see waivers.
Member DeBarmo.
Board member DeBarmore, since we just let essentially all the people have access, I think it makes sense to date the pool to allow for the person who's responsible to determine who has access. I just will call for the record the complete and total disparity we have between those who have access inside a pharmacy and those who have access outside of a pharmacy of all the same drugs. Odd. It's an odd thing, and my future board members something to consider.
Member Hall.
Member Hall, rather not see the waivers.
Member Beeman.
Board Member Beeman.
Not that I don't mind seeing waivers when appropriate, but it sounds like this rule will need some attention. Given that one waiver was approved in 2010 with no limitation. And also given the changes surrounding physician associates that are coming into play. And that things have changed a lot since whenever they were looked at. So I would say, yes, let's reevaluate these rules. Thank you.
Member Doyle, I have the exact same opinion as, Board Member Beeman. Member Chin.
Member Chin agrees with that, and I do like the dipto language. Instead of reinventing a wheel.
Member Joyce.
For Joyce, so, PA access, definitely. LPN access, maybe, and MA's, waiver, but, it sounds like we're gonna review for all three, but that's my preference. PA, yes, LPN maybe, and MA waiver, should be waiver only.
Board Member Patel.
I remember, but yeah, I would definitely I would like to see the waivers, but it's just does not make any sense that we have licensed technician who can't allow to be not only in pharmacy, drug room, medication cabinet, nowhere near the drug, but then we have unlicensed candidate, they can enter into the drug, access the drug, and I think I was confused and I'll remain confused about that. Thank you.
Any further discussion? Hearing and seeing none, I had counted that we had 2 persons for waivers, 1 person for waiver or rule, depending on the subsection of licensee or non-licensee that we're speaking of, with 5 others for rules. And so it appears as if we want to go down the rule pathway. And so the next question is, where would we place this in the priority of things? So if that be brought up, the priority, in with Board Member DeMar, how do you see this?
Farmer, I will abstain from.
Member Hall?
Member Hall. I don't know. Number 6. The 6.
Board Member Beeman?
Member Beeman. Question, I guess. Do we know if any of the changes around the physicians, assistants, associates are going to prioritize these for us?
Dr. Davis, we do not anticipate any other changes to our rules because of that. We very rarely even, I don't know if we mentioned physician assistants in our rules at all. Because we got rid of the speedos, what was the, Chrissy? Supervising physician drug outlets when the PA rules or PA law and rule were updated so that they're not working under the supervising physician anymore. They now work under like a collaborative agreement, sometimes with the facility. So we got rid of that drug outlet category. So we don't anticipate any other rule changes.
So we're not looking at 5.
Board Member Doyle, my best guess is that the most like thing that's on here, to the question at hand is probably number 10. And so that's what I would suggest. And perhaps future board members or staff, if they identify that there is serendipity with this, with some other rules that they're having to tackle, then it may come up at that appropriate time. Richard?
Board Member Chin, I don't see this as a high priority because we don't get these SBARs that often. And so I think 10 is a great number. But I would also suggest that, we don't do just one rule at a meeting. And sometimes you might have, like this little tiny space left when these are all big things. And if there's a little tiny thing that can get stuck someplace, I would suggest that maybe board staff be allowed to take a tiny thing and stick it someplace that it might fit. Because I think this is honestly a very tiny thing.
Member Joyce?
For more Joyce, yeah, I mean, the topic itself seems like something we could discuss and take care of in one meeting, maybe. You think so? One meeting? Matter of minutes, okay.
I don't think so.
Yeah, exactly. So I mean, that's a kind of my point. So regardless of where we place it, it's something that can be done quickly. So if we put it in NPDO, it is related to that, and we can knock it out at that time, or we can knock it out quickly. Number 5 or 6. Yeah, we can just put an NPDO. That's fine.
Member Patel?
Member Patel, 15.
I think that's the last one. Of course, we did 14, so we added one. So she said 15. Okay.
Member Hemmons?
Member Evans, I voted to keep the waiver, so this doesn't apply to me.
She's refused. Ian's doing the one too.
So that would be 9 point something.
Yeah.
Would essentially be in the number 11-ish tie for number 11.
Staff Member Davis will amend this. You can see we amended it from yesterday from the further discussion already because we had added in the RDSPs. And then this is just going to be kind of that living, breathing document that helps set priorities for agency staff to work on. Thank you.
Again, for clarification and transparency, the way that I calculated that number was a 10 from Chin, a 10 from Joyce, a 15 from Patel, a 6 from Hall, a 5 from Beeman, a 10 from Doyle. So we got 6 scores, and they totaled up to 56. And 56 divided by 6 is 9 point something. My long division. I believe that concludes conversation around those 3 SBARs. We have 1:54 p.m. We will. Is it staff suggestion that we delay the SBAR for OVM, and we have other guests that are specifically slotted to time?
How long do you think you need? Oh, great. How much time do you think you need for it?
Would our guests be available to begin maybe a couple minutes late and not specifically at 2 o'clock?
Lindsay, is that okay with your schedule as well?
Yeah.
Thank you.
Absolutely.
Okay.
We appreciate the flexibility of our guests for our budget discussion. So we'll move on to the SBAR for the OVMA. Please note that the next request didn't arrive in time for the meeting renotice process, but will be presented in real time and included in the board meeting summary. Staff member Effermoff will lead us through discussion.
Thank you, Staff Member Effermoff. Just to orient everyone, this is mailing, well, will be, I guess.
Well, it's
G3 for those on the phone to be able to see on the line. We also, just for board reference, have the Executive Director of the Oregon Veterinary Medical Examining Board with us, Pete Burns. Their Inspector Investigator Ingrid Nye on the phone, and Emilio DeBest. If there's any additional questions the board might have, they're here to support and answer as needed. So I will go ahead and give the background information and then hand it back to board president to facilitate the discussion. So at this time, OVMB is requesting an extension to their previous DIPDO registration exemption. So if we look at the background, the regulation that applies here, as part of the DIPDO registration requirements, there is a time-limited waiver that the board may grant exempting DIPDO registration when a practitioner's licensing board submits a request to the board with a plan to annually inspect the dispensing facility to the standards of the board. So this is the third time the board is seeing this. So back in 2018, the board reviewed and approved a waiver for 3 years. And then in 2021, the board also reviewed a follow-up request for an additional 3 years. So at this time, the waiver is dying as of June 2024. So the need to get this to the board right away. We do apologize. We didn't have all the documents together for you, but we will go through them thoroughly at this time. You can see the history related to the background. This is just the information that was discussed and contemplated at the time of the June 2018 board meeting. You can scroll through a little bit. A lot of this is going to be repeat history. So this is just to give the board a little bit of background of what was contemplated and reviewed at the time and to really show the incremental steps that the vet board has put together, included rulemaking and others to be in alignment with what the original request was. So it's showing their continued diligence to meet the request of the board at each re-up. So at this time, we are at the June 2024 board meeting, and we are going to review the assessment of the written request. So the vet board has 701 licensed facilities. And if this waiver is not granted, the board would be required to register and inspect all of these facilities to meet the DIPDO registration requirements. So I think it's important for the board just to keep that in perspective too, as you make this decision, understanding potentially staff resources and time related to if this was to be denied. Here are the questions that we had asked the vet board to provide responses from. These are all generated from the last request, so what you had assessed. And we will dive into all of these in the actual response here in just a second, but you could just take a moment to look at all the basic questions. We're asking how they're going to meet the requirements as the Board of Pharmacy requirements for inspections. We asked them to provide any additional changes that has happened since the last cycle. Also within the last cycle to provide what type of registrants, the locations, the frequency or cadence of their inspections, how many locations were inspected. So they'll have some numbers that they're going to provide. And then how do their current rules align with BOP rules related to the DIPDO rules, specifically with security, acquisition, storage, dispensing and delivering, labeling, drug disposal, and record keeping. And then also providing a copy of their current inspection, self-inspection form. You can just scroll down. We'll go to the actual response from the medical board. All right. So as the board can see, as of May 2021, the vet board adopted minimum standards for veterinarian medical facilities and veterinarian practice, which mandates compliance with DIPDO requirements regarding drug security, acquisition, storage, dispensing, delivering, labeling, disposal, and record keeping. During that timeframe, they did provide it to board staff to review and ensure that we didn't have any additional comments to make sure that those met the same standards. Those are still currently in effect at the vet board. And all licensed facilities must submit and complete a pharmacy self-inspection checklist annually. And they submit those for review at time of their registration. They also conduct on-site pharmacy inspections to review that self-inspection form. The question that came up on the last round is that were all facilities being inspected. They did provide clarification and make modifications from that previous request, and they do now inspect, or have been inspecting, I should say, all facilities. And I believe it was the American Animal Hospital Association accredited facilities in the past that were not being inspected, but they did add that to the list and are currently inspecting all of those. Just to also note, they do register all facilities, but they're only going to be inspecting those that would meet the same criteria for DIPDO as for us, so only those that are dispensing. So the real meat of all the information the board's looking for, part of their inspection factors, what they're looking for related to compliance with their rules, highlighting again that they are inspecting all of those facilities. They provided a little additional information as there are different practice applications for their veterinarians related to being able to dispense donated expired medication, and they check to make sure that it is within the requirements of their regulations, and also prescription only pet food. So they called that out specifically for the board just to know the difference there. Including the inspecting the veterinarian facilities. Here's the checklist. They've adopted rules that are not only in compliance with board DIPDO, but also DEA requirements. They mandate the submission of the self-inspection form, and they conduct initial reviews of the submitted checklist and documented non-compliance issues, and conduct annual on-site facility inspections to ensure that they're in compliance with those regulations. So to the numbers, 2022 through 2024, we talked about they have 701 facilities to inspect. They have an agreement that stipulates they conduct inspections every 2 years, modified to be in alignment with ours, which is the biennial inspections that we currently do also. So they submitted their on-site inspections as of the current cycle for them. They weren't able to complete all of them. They did have some staffing changes, so they now do have a full-time inspector to be able to go out and complete those inspections, as many state agencies are dealing with staffing shortages. They also provided by year, since they were last re-upped, of the total that they were able to inspect. Again, everyone recovering from a post-COVID world and being able to get out there and inspect. The numbers are slightly less than they would have anticipated due to those situations. That's just clarifying more of the conversation related to that. And would hand it back to Board President Doyle for any additional questions or discussion. Thank you.
Thank you, Board Member Doyle speaking. We'll go around to see if any board members have additional comments, questions, or recommendations. We begin with Board Member Hall.
Member Hall, no comments or questions.
Member Beeman.
Member Beeman, no comments or questions. And I would be okay with this for a 5-year approval this time.
Board Member Doyle, it appears through this information that they are meeting my satisfaction for self-governance for the inspections, and I agree 5 years is appropriate. Member Chin.
Member Chin, agree with the 5-year, but I would also make a suggestion that this particular SBAR be put onto delegated to board staff to do. I don't think we need to see this unless they're not following the SBAR stuff. So if it's just, they need to check in with our board to make sure that their board is doing all the due diligence, and they can check off the same stuff and say, yep, everything's good, and that be delegated to staff and not have to come back to us would be great.
Or Joyce, yeah, I agree with that. This could be SDA. And at this time, 5 years and approved, of course, looks good.
Member Patel.
Member Patel feel comfortable. When they're storing the drugs, and yes, I know, hopefully the Oregon Veterinary Board, they're doing their due diligence. And the drugs that come under Board of Pharmacy, storing and dispensing. So, like, that cannot be just the reason that is burden and resources problem for Oregon Board of Pharmacy. That's why we want to, give a waiver. That's something I would be opposed to this one.
Evans?
Board Member Hibbett, Compliance Director Everman. So this is the third request, so it'll be 9 years. No, 3. 9.
Remember-
3, 3, 6.
We're at 6, and this would, yep, depending on how the board wants to.
So, Board Member Evans, I bother to keep doing this every 3 to 5 years.
Staff Member Aftermath, currently in rule, the requirement is that they would have to have a time-limited approved waiver by the board to permit their licensees to be able to not be required to register with the Board of Pharmacy and have the Board of Pharmacy regulate their dispensing activity.
Remember Hemmings, so is this different from the one that you mentioned that there was no time frame put on it that we discussed previously?
Correct. These are different regulations. The previous waiver discussions were related, sorry, Staff Member Aftermath, the previous discussions were related to the CHC registration types, and this is related to the dispensing practitioner drug outlet registration. So different registration types with different regulations.
Thank you.
Member DeBarmo?
Member DeBarmo, so it's in rule, not statute,
Correct.
something that can be changed in the future.
Member Aftermath, but that is the will of the board.
I mean, approving it for 5 years.
On around once, is there any other questions from board members or staff or for OBMEB representatives? Board Member Patel?
Board Member Patel, question for compliance officer, just to be clear, so they're supposed to get to license registration. That's in our rule. We are giving waiver for 6 or 7 or 8 years. Understand, right? 5 years. Not 5, no, we already give 2, right? Before this, so now this is.
Staff Member Efremov, so if we tease out the board's authority of regulation over drugs via statute, then we carve out the dispensing processes and those that are regulated with the dispensing practitioner drug outlets. We look at those who meet the criteria via rule, those that are dispensing greater than 72 hours, that are not in a unit of use container, that cannot be broken, all of those different criteria. If an individual meets or a facility meets those requirements, they would be required to register with the Board of Pharmacy to be a dispensing practitioner. But if there is the meeting of OAR 855-043-0510-11, if another licensing board would submit to the Board of Pharmacy a request for a waiver to exempt their licensees from having to register with the board because the board has reviewed and approved their plan to annually inspect the dispensing facility to the standards of the Board of Pharmacy, the board has the right and the authority to approve that.
In other words, if different board come that, hey, we want waiver, then we will look at it,
Correct.
then we can Board of Medicine.
Member DeBarmo, if they will inspect to the same standards that our board inspects to the dispensing practices. The vet board does actively inspect.
Thank you.
Other questions or comments?
Board Member Hemmett, so in essence, what we're doing, we're delegating something that we would usually do to them.
AG Bertoni, yeah, you've given yourself, you've got a bunch of obligations, and you're saying that for another state board, so not a small school district in a rural setting, you don't know who's there, but another state board, you've given yourself permission to give it to them. At 3 years, 5 years, you could do 10 years if you wanted to. But you have made it a time, by rule, you've made it time bound. So you're not doing it unto perpetuity. You do have to come back and report back to this board, because that board has done on 2 occasions for 3 years.
Board Member Hemmons, is there any, do they just have to send us information to let us know? I mean, how do we have assurances that they're actually meeting the standards? But if you were to go out yourself to conduct that inspection?
Staff member Efremov, so they are getting a waiver for 3 years or 5 years or 10 years or whatever. We would assess at the time the information they bring back and bring that forth to the board. There isn't necessarily any additional oversight that we proactively do other than to trust that they're following that waiver. I can share though an example of the previous cycle from 2018 to 2021. Nope, I apologize, 2021 to 2024. There was a Secretary of State audit that had occurred for OBMEB, I apologize, it's late in the day. So we did proactively reach out, ask additional questions. So part of staff's assessment to bring forward to the board is we do further investigate. We look at the previous approvals, what was concerning, what the board's looking for, how things have changed, where is the standard of the practice today. We do ask those questions and ensure that as part of the board reassessing that you would have that information to make those decisions.
Remember Hemmons, so over the past 6 years, there hasn't been any discrepancies or concern based on the information that you have received from them, correct?
Staff member Efremov, there was some things that had, just to be accurate, there were some things that were raised related to certain abilities to have rules in place to be able to inspect. So it wasn't concerns necessarily, I should say, that it was giving them the opportunity and the time related to COVID occurring and also all of the other changes with staffing that had happened that they needed to require registration, then they needed to create rules to meet our standards. So they have incrementally met those. There were times when they weren't there yet. It's not concerning because they were taking actions to get there and we monitored and tracked that. But there were times that there were additional things that needed to be met.
Remember Hemmons, thank you.
Other questions or concerns from board members?
So one last question. So the reason we are delegating this one to another agency, even though it's come under our purview, is because of the resources. Or no? That's what I heard, like, sorry.
No, I apologize. I was just, staff member Efremov, I would give the board the opportunity to speak why you're approving it or not from your perspective. Historically, what I have heard is that it was a compelling argument to meet the standard of the language so that the standards were being met by that agency, that they are the ones that have the first knowledge related to veterinarian practice and the ability to assess that dispensing at that site. We also have worked with them and their inspectors to train their inspectors. We also have given them tools to create their own self-inspection forms. From my understanding, it's not a resource-driven decision that the board has made, but I would defer to the board members that if they're present that have voted before on the rationale for voting or today what your rationale is. Thank you.
Board Member Doyle, due to the time being 2:15, either if there's more comments or questions, then I would put a pin in that and we'll begin the other topic. If there are no other further questions or discussion, then I would call the question. Is there greater interest to continue the conversation? Seeing and hearing none. Is there a motion to move to approve the request from the Oregon Veterinary Medical Examining Board as presented for 5 years?
So moved, board member Chen.
And then Board Member Joyce. Motion has been made by Board Member Chin, seconded by Joyce. We'll call roll. Board President Doyle, yes. Board Vice President Chin.
Yes.
Member Beaman.
Yes.
Board Member DeBarmore. Board Member Hall.
Yes.
Board Member Evans.
Yes.
Board Member Joyce.
Yes.
Board Member Patel.
Abstain.
Motion passes to approve the OBMB request. We now transition to our guests. We will be discussing a high-level financial / budget update, beginning with Executive Director Fox.
You, Board President Doyle, and members of the board. Today we have with us Lindsay McFadden, DAS Senior Fiscal Analyst, virtually. And in the room, we have Hari B. I don't want Hari say his last name. I'm not going to butcher it, but Hari is our CFO, Assistant Policy and Budget Analyst. Lindsay's going to go first, and she's going to give you the perspective of our finances and our budget. And then Hari is going to provide the budget development process in the state. So Lindsay, I'll turn it over to you.
Thank you, Director Fox. Good afternoon, everyone. My name is Lindsay McFadden. I am your agency's fiscal analyst at Dash Shared Financial Services. Just to kind of give you a little bit of an overview of what I do for your agency is I work with Director Fox and your CFO analyst, Hari, to help write and maintain your agency's budget. That's a very short version of what we do for you. I kind of work with Director Fox and your CFO analyst to write the budget. And right now we are working through building AY27's budget. We just passed CSL audit, which is the current service level, 2 weeks ago, and we are in the ARB phase of the budget build, which I will be entering for your agency by the end of this month. And then we will be on to the governor's budget phase. Also, what we are currently working on is your year-end close entries. So it is a very busy season for my part. So is it okay if I share my screen with you?
Yes. Lindsay, this is Rachel. So I made you an organizer, so you should be able to share your screen. So go ahead and I'll.
Giving me the permission. So
Okay. And I'll just let you know because we're projecting you if we can see it. Okay.
Oh, good.
So yes, if you could make that a little larger if possible.
Is that better? Here, let me
That's
see
better.
if I
Yeah.
can. Is it better?
Actually better. Yeah, thank you. I
Okay.
think that's as good as it's gonna get.
Okay, I'm just gonna move you over here. Okay, so this is a very high level view of your agency's budget. Here it is broken out by each of your programs. And you can see here that this is your operations program is the only program that actually receives revenue. And I'll kind of go into that here in a minute. Right here, we can see that the compliance program, this is where most of your expenditures are being spent right now. So these numbers are actuals through April, because we're we lag behind when we get actuals for each month. So May actuals wouldn't come out until next week. So I wanted to give you actual numbers. This is through April. So right here, you can see about 47% of what has been spent through April is through your compliance program. The other majority is through your operations, which I would expect. Of your 11.3 million legislatively approved expenditure limit, you have spent 4.1 million, which is roughly about 36% of the budget. So I just kind of wanted to give a very high level overview of that. If I don't have any questions, I'll just keep moving on. Is that okay?
Yes.
Okay. So next tab is a little bit more detail of what I just showed you, but it's not broken out by your programs because your whole budget is one fund. And this column is going to be what you were legislatively approved to spend and what your budget was written to receive in revenue. So this column, though, is what we have actually received in revenue and what we've actually spent, plus what we are projecting to spend for the rest of the biennium. And if we kind of just scroll down, I just wanted to point out a little bit about your budget is you spend 71% of your budget is on personal services, which is payroll. Just to kind of foreshadow the next part of what I'm going to talk about. So right now, you are projected to, at the end of the biennium, currently we are projecting an ending cash balance of 3.8 million. So when we plug in these numbers, this gives me a very, very rough guess using the information that we know at this point in time, using inflation rates that we know right now to project out a couple of biennium to see what your revenue and our expected expenditures will do to your budget in a couple of biennium. And right here, you can see this is the current biennium that we're in. We
Lindsay,
ended.
can you make that a little bit larger? We're having a tough time
course.
seeing it. Thank you.
Is that better?
Thank you so much.
Yeah. So this is our current biennium. We ended last biennium really well. And we brought that balance over into our new biennium. And this biennium, we're projecting to end fairly healthy. However, as we move along, if our revenue continues in the trend that it's going right now, which is roughly actually 6% increasing. I gave it 6.9 for this estimate, but when I was looking at the numbers, it's probably closer to 6, so this might be a little nicer than it will be. We're still slightly early in the biennium to give a better view of the revenue that will happen. But as we look at this, I'm projecting, or we are projecting, that you're going to go negative in your ending cash balance in AY29. The expenditures are going higher than the revenue is expected to go. Mostly because you guys are, like I had said, most of your expenditures is in your personal services. So that brings me to our revenue. I put something together that kind of gives, this is last bienniums here below here.
Thank you.
A little better.
Yes.
Okay, so the top section is this biennium. The lower section is next biennium. And this column right here was the percentage difference between the two each month. And you can see that there's a lot of negatives in our, this is the actuals this biennium. And to date, these numbers average a 6% increase. But when I pulled numbers to kind of look at the overall, your revenue is going up 6%, but what is the expenditures going up? And the expected increase is about 9% of expenditures. The COLAs that came out this biennium, they were not something that we were able to budget for because that was an unknown factor at the time when we wrote the budget. So COLAs, high COLAs definitely has impacted the board.
Does everybody know what a COLA is? Lindsay, could you?
Oh, I'm
please?
sorry.
Yes.
It's a
Thank
cost
you.
of living adjustment.
Thank you.
It's a cost of living adjustment that gets done to the payroll. So typically, in a biennium, we would see about a 5%, and how that's broken out is roughly a 2.5% increase annually to payroll or to everyone's salaries. And this biennium, it actually went up 13% I think it was like 13.5%. So that was a huge increase, way higher than we could have anticipated. So the other thing is that I was looking at like where your revenue is, most of your revenue, obviously you guys are a licensing agency, and you're an other funds agency, which means you rely on mostly your fees and your licenses. So licenses, I'm not sure how you could really control that as much as the licensing, the fines and forfeitures is also where I found that had decreased quite a bit when I looked at just the actual line items. And when I looked at a couple.
Yeah, sorry,
Yes,
Lindsay, can we decrease that? And then could you also explain maybe to the board what's in the fines and forfeitures?
Well, it's the fees.
So collected,
I
like
mean,
civil penalty delinquent.
Yes, sorry, yeah, it's your civil
Okay.
penalties and your delinquent fees. These are the two items in this budget line. And I highlighted your delinquent fees in FY 21 was 66,000, and then it dropped pretty significantly in 22, definitely in 23. It's slightly higher in 24 than it was last year, but way less than it was just a few years ago. Your civil penalties have also gone down from, definitely this fiscal year, because this fiscal year is over in 2 weeks and we're only at 66,000 opposed to last fiscal year of 146,000. So there was a definite difference, and just trying to find, where there's a change to kind of give you an idea of where the revenue is going, opposed to your expenditures. So that is all I have for the visuals. Pardon?
Member Doyle, I have one question for you on that screen. The civil penalties, you and in conjunction with staff, that value represents all of the civil penalties that we issued as a board for the last year. So any adjudication of cases, this is the result. And we're assuming that all penalties have been collected.
Yes, that is correct.
That's, yeah.
Well, I'm sorry. This number right here, yes, you are correct. That would be through last Friday. So if I received anything from then, it wouldn't include that.
Yeah, just
Staff member Hennigan.
The staff member Hennigan, I just wanted to speak to the delinquent fees. We had implemented the new database in 2019 and the online services, and we found with the efficiencies that we had, the board was able to change our rules so that the delinquent fee didn't kick in until after a license expired, where previously it had kicked in a month before the licenses would expire, as an incentive for people to renew earlier. So that was one thing that we were able to, that the board was able to do to assist our licensees because of the efficiencies of the new system that we had. We did that in mid-2022.
That would make sense then why the numbers changed pretty drastically.
There any other questions for Lindsay before we move forward with Hari from the board?
Member Hemmons, I was gonna ask a question about what was delinquent fees. So define delinquent fees for me in this context.
The staff member Hannigan, the delinquent fees are, it's a late fee. So for a license that's submitted, if someone pays after the license expires, there's an additional fee that's added on.
And so it's not if someone pays their civil penalty or doesn't pay their civil penalty.
Correct.
This has to do with renewal of license or license.
Is correct.
Member Patel.
Board Member Patel, so I understand about, there's controlling and non-controlling factors. So revenue, we can only control so much. But for the expenditure, so you said our total expenditure is about 11 million, and then 70, and major chunk of the expenditure is the personal services, and out of that, 71% is the payroll. What other personal services we are?
Personal
thinking?
services is payroll. It's payroll and your, like the retirement, PERS, that sort of thing is all considered personal services. So paying for the staff is 71% of your budget. Which is, I think is pretty common for a licensing board.
Let's say that.
So what you have here as we get ready to, if there's no other questions for Lindsay, shift to Hari is looking at our budget where we are, expenditures are increasing, revenue is decreasing, and within the next two, what we're trying to do is project over the next two budget cycles, 25, 27, and 27, 29, and really trying to pencil in kind of where we're going to be at that point in time. And as it states right now, we're heading towards a deficit within our budget based off of these figures today. And I'll turn it over to Hari, and Hari will be able to provide where we are with building our budget and any other guidance from his office as it relates to these numbers, the CSL numbers that we submitted and provided to the CFO's office. Hari, I turn it over to you.
Hi, everyone. My name is Hari Velapondian. I go by Hari. I am an assistant policy budget analyst with the Chief Financial Office. I'm just going to give you a little intro basically on what my office does, what some of my responsibilities are, and then my main kind of interactions with the Board of Pharmacy. So the Chief Financial Office is the central budget office for the state of Oregon. My main responsibilities are so handling any type of budget requests that might come out of the agencies that are assigned to me, whether that's staffing positions, additional supplies, whatever it is that you're requesting. I'm kind of the go-between between you and then the governor's office and the legislative office. The biggest responsibility is all of the state agencies run on a 2-year budget, which is what Lindsay was just talking about. Right now, we're in the 23-25 biennium, and we're planning our budget for the 25-27 biennium. Putting together the 25-27 budget is it's like a process, and that's kind of what I'm going to talk you through right now. It starts kind of in early January of this year. I should say this also just because I don't know how comfortable you are with the time spans. The budgets run from July to July. So right now we are right in the middle of it, kind of. We're about a year through it. The next biennium will start in July of 2025. So we started the beginnings of starting our 25-27 budget basically this January, where we got Board of Pharmacy to turn in just some rough ideas for policy option packages and legislative concepts that they might be considering. I look at those along with the governor's office advisors, and what we're trying to do is kind of get a 1,000-foot view. I look at my agencies and the groups that are assigned to me, and the governor's office looks at agencies statewide to kind of be like, what are we getting asked for as a state? And what can we afford as a state to put out? And are the things that we're going to be supportive of in agency requests and governor's budgets reflective of the same types of ideas? Or being equitable across the state. So once that initial list is turned in, I take a look at it, and we've kind of been working with Jamal a little bit to give him some feedback, and the rest of the board, to see where the governor's office stands on some requests. And then we move into the CSL build, which is what Lindsay just got us through, which is awesome. Thank you. And the way that the current service level works, that's what CSL is basically we take your current budget for 23-25 and we inflate it with a bunch of standard inflationary factors that are provided by my office. A really common one is, so services and supplies is the other big chunk from personal services, and it's basically everything else. And those inflate at about 4.2%. I'll talk about some of the personal services. Actually, I'll talk about it right now. The personal services also inflate a good amount, as Lindsay was indicating. And, 71% of your budget is personal services. She talked about how the COLAs that we just received this year and then are going to receive next year are two of the biggest, if not the biggest, that the state has ever gotten. They're about 6.5% each year. I think the last two were at like 2 point something and 3.1. So an average of 2.5 sounds about right. Some of you are state employees, so you know how our step system works, but for the board members, for every additional year of service, you also get a step increase, and those typically come out to about 4 or 5%. So if you want to think about somebody who started in, even me, like, let's say you start as an employee, in the next year, you're going to get the 3% COLA, 4%, 4 to 5% step increase, another COLA, and then another step increase. So personal services costs can jump up really, really fast, really, really quickly. And that is kind of what makes it tough on majority personal service agencies. So basically that is what we do during CSL. We take our current budget, we inflate it by all the factors that we're given, and we get a guess for what that's going to look like to maintain exactly the services we have now in the next biennium. After that CSL budget is developed, which for reference is also kind of what Lindsay was using to project out our costs, is the CSL budget that we just developed for 25-27. We move on to the agency request budget, which, as Lindsay indicated, is due kind of at the end of this month. The numbers part and the narrative part will be due at the end of July. That budget includes everything that was in the current service level, plus a couple of items that the agency will request in the form of policy option packages. This year, we're kind of doing it slightly differently, where even the things that are going in the agency request budget are being reviewed by the governor's office to make sure that they're going to get some more support. Part of the reason we're doing this process is because in the past, agencies will request whatever they need, and then it can be a really, really tough conversation come governor's budget. We're just trying to get everyone involved in the process ahead of time. So if we know there's things we can't provide or there's things you can't afford, we're trying to let you know that now instead of, getting your hopes up, waiting 6 months and then dropping the hammer. Okay, so that agency request budget, by the way, at any point, please stop me if you have a question. Monologuer. After the agency request budget gets turned in, my office reviews it as a part of the governor's recommended budget. Take a look at all of the agency request budgets turned in. We talk about it with the governor's office advisors and the governor herself. And she puts together a recommended budget using the agency request budgets that were turned in. That recommended budget comes out December 1st of this year. 2025 session will start in January. And during session, Director Fox and I will present that governor's recommended budget to the legislator. No budgets are official until the legislator passes every item that's on there. We'll basically go to this place, it's called a Joint Ways and Means Committee, go to the budgetary committee for the legislator and present our budget. They'll basically okay it or not okay it. There'll be discussion on why we had stuff in there. And what comes out of that legislative session becomes the legislatively adopted budget. So that's how we're going to get to the 25-27 budget. Okay. Now I'm going to talk a little bit about Board of Pharmacy specifically. CSL build this year showed that just from us inflating our costs, your cash balance is going to drop a pretty significant margin. I can't remember the exact numbers that were on there, but going from about 8 months of ending balance to, what was it, Lindsay, maybe like 3, at the end of the next biennium. And so you can see that if that's gonna happen a second time in 27, 29, that'll put you in a negative balance. With BOP being an entirely other funded agency, which means all of your revenue comes from licensures, fines and forfeitures and civil penalties. You don't have a lot of wiggle room when your costs go up. Other larger agencies are general funded, and what that kind of means is their revenue comes from like our income taxes and other state taxes. They're not creating their own revenue internally at the board. So when they see inflated costs like this during CSL bill, their general fund will just increase by that much. They don't feel the pressure that smaller boards do. When your costs increase, you have to account for those costs with the cash that you have on hand, which is why it often will lead to a fee increase. Fee increases and expenditure cuts are really the only way to deal with increasing costs at a smaller board. On top of the recent COLAs, Board of Pharmacy is also facing, and it's tough because these COLAs and pay equity things are really, really good for staff members and for workforce development and staffing. It's just tough on the budget. There's also a pay equity project that's happening right now that does exactly what it sounds like. It's, there have been different hiring practices across the years, and they're basically retroactively going back and being like, some of you should have started at a higher step, based on any number of factors. Education is a huge one. Not everyone was given credit for their education in the past. State government service charges are another large cost increase. I don't think that hit the Board of Pharmacy specifically as hard as it hit some of the other boards. But those are charges that include things like Lindsay is an SFS analyst, which is a central government state agency service. She's basically works at an accounting firm that you guys are using. So sometimes, we raise those fees and those can hit the agency on the back end. I say all of this to just indicate that the fee increases that you guys are going through are like not abnormal for a board or health licensing board of this size. This is kind of how everyone has to deal with these rising costs. I've been working with Director Fox a little bit to explore the fee increase and kind of see what would be standard and mirrored across some of the other health agencies, as well as the other things that we consider when looking at a fee increase is how long has it been since you guys had your last fee increase? And I don't know how much it's been talked about before at the board, but it's been a little bit since you guys have seen a significant increase. 2019 is the last increase you had, but some of that was not really official because you increased your fees, but then you went from providing a 1-year license to a 2-year license, and so it ended up being net zero. The last real substantial fee increase you had was in 2011, which is about 13 years ago. And if you can think about how much all of your other costs have gone up since 2011, it is honestly wild that you made it this long without needing a large increase. The other thing that we do when we're considering fee increases that I think is really important is looking at how much do the states around Oregon charge for the exact same license, because you don't want to increase your fees so much to where it becomes like a competitive advantage for pharmacists to work in Washington across the border rather than work in Oregon or work in California or Idaho instead. So you want to make sure that when you increase your fees, they're staying in the range of the regional. So yes, that I didn't come up with a great conclusion, but really I'm going to be working with Jamal in the next coming month or two, and the rest of the staff at Board of Pharmacy to keep moving toward the agency request budget and the governor's recommended budget, and hopefully make sure that all of the requests in there, whether it's a fee increase or the policy option package, will be supportable on board revenue and be reasonable and be able to get through the legislator without any complications. I know I just talked for 10 minutes straight. Does anyone have any questions?
And I think the fee increase was a while even before 2011. Even before 2000, early 2000, but not bad.
I know that they've increased in my career. I'm not joking.
Microphone.
Member Chen, as a board, we're required to keep a 6-month operating budget at all times. So do they fine us when we don't?
So you don't get fined. It's just not fiscally responsible. That's
Okay.
kind of where it shakes out to. And like, something that I think both Lindsay and Director Fox alluded to is like, when we look at these fee increases, we don't want to do them so that your ending fund balance will get to 6 months exactly for the next biennium, because we see these CSL inflations. And so really the goal is to make the fee increase large enough to where like 2 to 4 biennia from now, we project at the end of the biennia, you will still have those 6 months. So every time we look at those increases, that 6 month balance is the thing we consider the most.
This board member Chin, just one other question. Do other licensing agencies who depend on licensing fees, do they typically have routine fee increases to continue to support their increases? So,
Yes.
so just somehow or other, we weren't doing as a, okay, never mind. I think the writing's obvious.
Yeah. It's, typically it's better for agencies to do, so I probably should say that as well, but yeah, typically agencies do fee increases, more frequently. The goal is every 2 to 4 biennia, so 5 to 7 years. And that's both if, that's like how long you want your fee increases to last, but if it's been that long since your last fee increase, you probably should consider another one also. And that's mostly just to stay ahead of it. If you do 2 15% increases, people might be more receptive to that, or stakeholders might be more receptive to that than one large 30% or 40% increase, which is what ends up happening. Even if you're able to sustain your board barely for 8 to 10 years, you end up needing a really large increase at the end of that. And even though you're not increasing past what is the standard in other states, it feels like a huge increase because you haven't done it. So
Member Hemmings, what factor do we know, we know if, I'm assuming yes, but how do we factor in, exit, a decrease in, licensees in terms of how that's impacted our revenue? Has there been a significant decrease in licensee for the board?
It's been flat and pending proceedings.
So there hasn't been an increase, board member Hemmings, there hasn't been an increase in people seeking licensure, which is generating revenue, paying fees over whatever period of time that we're looking at here.
Staff member Hannigan, we do continue to see our licensee growth. And I apologize, I don't know about percentage, but it does continue to go up.
Board member Hemmings, so we're seeing an increase in people seeking licensure, which would mean there's an increase of fees coming in that adds to our revenue. But the only thing that's driving the decrease in our revenue is the increase in personnel costs. Is that what you're saying?
kind of, it's, your revenue is increasing. It's just not increasing at the same rate as pay rate. Exactly. It's increasing, if it's increasing at 6%, your expenditures are increasing at 10%, and it puts a hole in you over years. Yes.
Dr. Patel, yeah, that exactly I was thinking. So, I have my business too. So either two things, revenue and your expenditure, right? So we can increase, let's say licensing fee, but is that enough to meet that deficit? You know what I mean? Is that enough? Because you say like it's substantial. Number two, that's the expenditure, right? So that's what we control. Your payroll, that's the biggest one. And then your inventory, in my case. So my question is like, what can we do? Because if you see the biggest chunk is 71%, that's your personal service expenditure. So to me, like, even though if we increase the fee, is not going to be quite enough. That means what that tell me that you have to decrease your expenditure. So I think we should focus on that.
And response to that, we're going to look across the board at all the expenditures as we have it. Currently, what the board agency in years past And you saw the chart that Lindsay had up there with the fines and forfeitures, and delinquent money that the board had taken in, and the fines piece from discipline that was imposed and all that. Those used to be higher, where we've been able to apply some of that to be able to help the agency in the past. With it decreasing and expenditures being higher, yes, 70% of personnel costs are continuing to go up, but it's also when we talk about the fee increase, any fee increase, we also have to take a look at the operations. So from an operational standpoint, what is needed for the board to operate, to function, to be streamlined, to be efficient, to meet the governor's 11 expectations that she has there, i.e. software. How do we do customer service better? What software, what innovation part of your strategic plan? How do we do that? We have to look at putting funds towards that. And so any fee increase, which because we haven't had a fee increase since early 2000, there potentially will be a couple fee increases that are going to happen in the near future. And that will not going to get us where we need to be. It'll get us somewhat closer to assist to address some of the operational needs. Some of the COLAs or any future COLAs, those items, we don't budget for it. It happens. So
the only thing I would add to that is that, because you're totally right, like if you're looking at your revenues are like eventually not going to be able to keep with your expenditure. So perpetual fee increases are kind of inevitable for a fee-based agency. It's just where all your revenue comes from. But I think you just have to consider that like your revenues are not being inflated and your expenditures are. So like we've been inflating your expenditures. Chicken was $1 in 2011. Now it's $2.19. So like everything you pay for is more expensive, but we've not been charging anyone any additional dollars in that amount of time. So it's like the amount of licenses you have are increasing, but if we slowly adjusted that income value the same way we've adjusted our outgoing value over the years, it wouldn't seem so large.
And the only piece I would add there is also the answer would not be as they're looking at expenditures, it's not rifting and laying off a bunch of staff. We have 24 members as well, and looking at that. And so hypothetically, if an agency looked at rifting staff and laying off staff, the work is still going to be there. The work is the work. And all it means is it's spread in other parts of the agency. We're already spread thin. The workload is already significant. So what we're trying to do is methodically look at projecting out several bienniums and looking at what we can do, what can we afford, what do we need. We may have some wants and have had wants in over the last couple of decades, but what do we need to operate and to meet the goals and objectives that you have already adopted in your strategic plan and meet the goals and objectives of our COO and the governor is the lens that we're using.
Board Member Emmons, I would say that you need more staff and not less staff, but that being said.
You say it again.
That being said, basically this is the first time we're having this conversation. And what is the rationale for not having an increase over the past, say, 10 years? Like, wasn't it? I'm not going to answer it. I just want to know.
I wish I can answer your question. I can only say we're here at this point. In my short 8-month tenure, is just making sure that you know exactly what's going on, because new governor, new budget process that's rolling out. We're all going through it. There's requests within the budget process that we had to turn in sooner in this budget cycle than we have in years prior. And so we're kind of flying a plane and building at the same time.
That's the Oregon motto. Board Member Hemmons, so what role does the board members play in the fee increase? What is our role as it relates to that process?
So, and correct me if I'm wrong, RA with Lindsay, but within the conversation and under the current process, CFO's office, governor's office, will be meeting with me and the team, leadership team, and talking about the needs of the agency. When we get the green light from the governor and she feels comfortable on what she believes is the need of the agency, she will provide direction to me to be able to have that conversation with the board as well as with the association and other interested parties of our profession. At that point, there's a long process because it's not easy saying you may need an increase, but you got to go through rulemaking and a whole bunch of other steps to actually get to that place. So we may start the process here, but it may be a year from now. Correct me if I'm wrong in the process, but it may be a year from now before it actually get implemented because interested parties need to have a say before moving forward, and the board will have its say in your board meeting sometime in the near future.
Member Hemmons, thank you.
Yeah, that sounded pretty right to me. You basically will put in your fee increase in your agency request budget, and then it will get put in the governor's budget. But again, no fee increases are. There's like an administrative process you can go through if you want to increase fees without the legislator's permission. But typically that's more of like an emergency situation type use. And then even if you do that, you still have to get permission from the legislator to keep that revenue. You'll basically go to 2025 session and be like, we did it's called a DAS 333 process. You write a fee memo, you guys approve a fee increase, you file with the Secretary of State, and then I write a memo to the director of DAS and they approve it. But all the revenue that you increase is not officially yours until the legislator approves it, and they have the right to tell you to give it all back, which is why typically it's better for you to ask in advance. And then once the fee increase is approved by the legislator during session, I feel like, and this is more of a rule of thumb, I don't know why they always do this. Feels like most fee increases typically take place in August or September. Session ends in July. And so I think there's just a natural 2-month buffer where you go through rulemaking and file with the Secretary of State and that memo gets written and all that good stuff.
I think President Doyle had your hand.
I had 4 small points that I wanted to bring up just for information. One, it's interesting that you brought up that last part. Coincidentally, I was going to say that not only haven't fees been increased, but there was approximately 10 to 12 years ago actually a fee decrease for licensees on a one-time basis, I believe, and because we had too much revenue, just a historical perspective. So I don't know behind the scenes, but as a licensee, it was broadcast by the board that the license for a 1-year period was going to be a lot less for licensees. The other thing that I wanted to point out that I noticed is that the civil penalties which we've issued, yes, they've gone down from $150,000 to $67,000, but those are a relatively small percentage of our overall budget. Our guest speakers had talked about bordering states license fees, and with respect to that it wasn't explained what those were. So for the non-pharmacists that are on the board, I just wanted to provide perspective that my licensure in California this year was approximately $550 for the biennium. So $200 more or so than Oregon. And lastly, with regards to the number of licensee applications or licensees granted, I think that a challenge that we're going to have is the continued decrease of students enrolling in schools of pharmacy, and that the number of licensees produced, at least by the two schools, or school and college of pharmacy in Oregon, is going to be significantly reduced. And so if we do have any increase in licensee number, then most likely it's going to be those persons who are moving to Oregon or wishing to have dual or multi-state licensure. And then that makes me think about the number of what our requirements are for working out of state and being licensed in Oregon to actually perform services for citizens of Oregon. So not suggesting anything, but obviously those are the out-of-state pharmacists are a pool of registration fees that could be available for us. Are there any other questions for our guests from board members? Executive Director Fox, any closing comments?
Just want to thank the board and please take a good look at Lindsay and Hari, because they will be before the board a few times a year to be able to bring us up to speed on what's happening in real time, actuals, and for us to have a robust discussion like today. So we really appreciate the opportunity.
Thank you. Thank you.
Thanks, Lindsay.
Thank you for our guests for presenting this information, and for Executive Director Fox and staff members for bringing this important topic and educating us. It is now 3:02 p.m. We're going to take a break, and we will resume open session at 3:15 p.m.